Good morning, everybody. Thank you for having me here, and I like being first, of course. I'm a practicing physician, internal medicine, working here across the street in one of the departments of this hospital. And each day, or almost each day, I deal with the patients. And lately, we noticed that there is a lot of conversation going around us, actually above our heads sometimes, about the role of this big data or health data in the life of our patients and what is more important to us in our lives. So we are feared to read in newspapers that the medical profession will be, in the best case scenario, different in a few years, but some are saying that it will not be even necessary to have us as physicians out there. It will be enough to have smart computers, smart data algorithms, maybe with social workers just to hold the hand of our patients, because our patients, they like to be touched and consoled, and computers are yet to know how to do that. But as a practicing physician, it poses certain questions to us. And so coming from this point of view, and also being an epidemiologist by training, I have a few thoughts to share with you. Basically, how do we see this thing? So if I ask you right now, out of these 5 things that are listed here, what is the difference in health effect of these highly discussed interventions in the life of our patients? Wearable technologies, Internet of Things, precision medicine, big data that we are here today, and free beer. The answer is that only one of them is associated with a positive health effect, proven to be associated with positive health effect. And somebody who already heard my talk knows which one of them. And it is free beer, of course, okay? Beer is good, and actually free is even better. And if you don't believe me, there is actually a consensus document based on many investigations showing that there is, in fact, a positive effect of beer drinking on the health of our patients. Of course, in moderation. We like moderation. And actually, there is not that much out there showing that use of the health data for purposes of the prediction algorithm and whatnot, smart medicine, is associated with any benefit to our patients or to physicians. So if you look on the new technologies based on something that is called Gartner cycle of hype, you know this, of course, from other different fields. So Gartner company that publishes every year this kind of estimate for every imaginable field of human activities. Basically, on the x-axis, you can see the time of the intervention or time of the project or time of the new thing that is out there. And on y-axis, you see how much it is talked about. So if you look at this, it starts from this innovation trigger. We are past this effect. Then it goes to the peak of inflated expectations. Then it goes to the trough of disillusionment, and then slope of enlightenment, and then plateau productivity. So last year when I showed that, or maybe 2 years when I showed this first time, everything that has to do with the health data and use of the health data to predict something or change treatment of our patient in a way that we think it should be done, we meaning those who deal with the data, it was right above peak of inflated expectations, where you see the machine learning stuff and the other things. From this point, it actually went a bit down. So it's a good thing, because right now I think we are closing to a trough of disillusionment. Many papers and many position papers in our literature, in clinical literature, saying that it's rubbish, don't use it, it has no future. So I guess we're in a good direction. I'm not sure that we'll get to the point that everybody here wants to get, but we're certainly into this direction. So things to know about clinical data and whoever plays with the clinical data. First, it is not collected for you, data scientists. It's not collected for you to do nice algorithm or getting grants or whatnot. Okay? The purpose of the collection of medical data has nothing to do with science. It has something to do with the treatment of my patient, records, legal stuff, and some other stuff. And because of that, you can actually guess what is the quality of this data, and hence what is the quality of any prediction algorithm that you have out there. Second, because of this, it has a very patchy collection. For example, we started collecting laboratory data starting maybe 22 years ago. They were computerized. But clinical data in outpatient clinic, we started collecting only 17 years ago. Data about medications in outpatient clinic, we started collecting 15 years ago. But data about medications during hospitalization, we started collecting only 2 years ago. And so everything is very, very patchy, and it's not one system, but actually a conglomeration of different approaches, different electronic health record system, and so on and so forth. The data that we collect is mainly data for sick people, okay? And hence the bias in any algorithm that you're going to build or do. Because we actually somehow, till now, we're not that interested in healthy population, even though our HMOs are called Clalit Health Services, Maccabi Health Services, and so on and so forth. We do not deal routinely with a healthy population, except for small population of women coming to deliver in the hospital or kids getting their vaccination. But the bias here is that whatever data points you see, they're usually collected for sick people or around illness. So the baseline is practically not known. It's coded very strangely because we have different system of coding of the health data. Some of them you know, ICD-9, ICD-10, and so on and so forth, but some are even more obscure than that. And on top of this, it's not that it's coded by universal approach, it's coded basically based on however I feel today morning to put the diagnosis there. And then the next one, the professional coder who is actually coding this into the numbers is also coding based on her or his own perception. There is actually very few QA, QC mechanism in place. There are very strange incentives sometimes when you collect health data. For example, American doctors are paid by the severity of condition their patients are. So they tend to overcode. For example, our patient would have, the same comparable patient will have less diagnosis than our American counterparts. Therefore, any algorithm that is based on our Israeli data will actually be not that correct if you try to apply this in American, vice versa. So, just to tell you a story that presents this problem sort of in real life, I will tell you something about what is called reverse epidemiology. A few years ago, somebody published a paper, and since then many, many papers about reverse epidemiology. Basically, it means that no matter what diagnosis you are taking or what outcome you are taking, if you're obese, it will protect you from death, fracture, stroke, MI, so on and so forth. It's better to be obese, okay? And this goes against whatever we know as physicians about the obesity and the effect of the obesity on the health of our patients from prospectively collected data. And so the question is why? Now imagine you have two patients, or I can imagine I have two patients. One is 32 years old with pneumonia and obesity, and the other one is 85 years old with pneumonia, sepsis, dementia, and the list of other letters that means basically that this patient is going to die within next 2 weeks, okay? So, and the second patient is also obese. And now the question, who has higher chances to have obesity in the list of the diagnoses? And the answer is straightforward, the first patient. Because I, as a physician, I do not feel comfortable discharge somebody with only one diagnosis, pneumonia. I want to have something more written there, so I will put obesity. But with the second one, after 22 diagnoses that are already put there and coded, to put obesity there would be just overkill. I don't need this. And hence, you can see the answer to the following question. Who is more prone to die within next 2 weeks? And obviously the second patient, okay, who is not obese. The first is not going to die, and this patient is obese. And here it is your reverse epidemiology in a nutshell, okay? So, what do we know till now about the use of the health data, again, not as a statistical or usual statistical exercise that we all do and publish papers and do randomized controlled trials, but under the premises of big data, if you want, in our field. So the example of Watson and health and cancer care, and you all know this example. Basically, I will scroll down to the last one. Basically, it's a system creating to help with the diagnosis and treatment. Patient with oncological disease was developed in Sloan Kettering, which is one of the two most famous hospitals in the world treating cancer patients, and was based on the IBM algorithm and so on and so forth. Right now, this project is almost shut down. One of the other two hospitals that actually tried to use this in the United States of America stopped using this, and the word out there is that there is no evidence that it helped in real life treat the patients. This project cost many, many millions, hundreds of millions of dollars for some of the hospitals. For example, the second one, MD Anderson in Texas, basically spent $39 million trying to accommodate this project into their health system, and finally quit the project, spending, $60 million. It's the same, 39, 60. So, but this project, IBM Watson won Jeopardy in 2011, which is basically very commendable. So, why I'm saying all that? Because up until now, we use the evidence-based paradigm to actually prove that something or use something in medicine. Basically, the burden of the proof is on us. We need to prove that whatever we think works is actually working. Basically, we need the proof of the efficacy and safety of any intervention that we are using. And right now, I think that the big data or data-based or data-driven approach is yet to be there. So just to finish in the next minute, why we think it is so? Well, first of all, more data is not equal more inference, right? So sometimes when you collect more data, and you know, for example, Americans are crazy about health checks. Like every year, people are going to health checks. But there is no data to show that this amount of information that you collect every year for your own health will actually improve something, okay? And quite the opposite. There are many examples in medicine when knowing more about the patients, more data points, actually will cause more harm. And this example includes, for example, mammography, PSA, X-ray for your back pain, okay? All these interventions are actually harmful. It's not that they are not useful. They're harmful to the health of our patients, but we have more data. So more data does not necessarily equal more understanding what's going on with the patient. More data, of course, it's more positive, and there are some tests that have a lot of false positive, and this is one of the examples. India bans TB serological test. TB stands for tuberculosis. And the last one, which is for me is probably the most important, it is that there is this magical thinking in some of our community of people dealing with the data, that if you take the patient's sodium level and multiply this by the level of his or her hemoglobin and divide by the age of his grandfather or grandmother when they married first, somehow you will obtain some secret knowledge about your patient that otherwise you won't know. Okay? That I can promise you right now won't happen. Even though, as I already told you, this is patent, so don't use this approach. I have the rights for this approach. So for now, doctors are somewhat reluctant to actually accept the idea that practice of medicine is changing and the data will play a role here. But I think that not only the doctors are to blame or being held responsible, I think that we need actually collaboration between data scientists and the other side of this road, Ben Gurion road, because we need physicians, especially young physicians, to understand that the future will be there. And if I have a luxury probably to go to my retirement practicing the medicine that is practiced for the last 2,000 years, probably the next generation won't have this luxury, and they will need to accept the idea that the data will be there. But how it will be there, it remains to be seen, and right now I don't have the answers. So, just to finish it, because I'm practically done with the time, or done with the time. We are ready to play with everybody. We are ready to be engaged. We want our young physicians to be in this room, and right now probably there are no young physicians sitting here in this room. And actually, even if we'll be holding this same conference in the hospital, still will be only few young physicians sitting in the room, but the understanding is there, at least from our side, that we need to start playing, and we need to be around the table where you discuss the data approach in healthcare. Thank you so much.
Maybe time for one brief question to Professor Novak.
Usually I'm a very optimistic person. No questions?